Hello, this is EMC 225. In this module 4, we're going to take a look at fluids and electrolytes. One of the most important aspects of pre-hospital care is the administration of intravenous or IV fluids as well as electrolytes. There's two main reasons for administering IV fluids in the pre-hospital phase of emergency medical care. The first one is to replace blood volume that has been lost either through bleeding or through potentially like diarrhea or in cases of dehydration. So in essence, it's to provide volume to get the blood pressure up. The second is to provide an easily accessible route so that we can give IV medications in an emergency situation. And one of the key things that's important for you to remember, and I'll say this time and time again, is that it is important to remember that particularly in cases of shock and in hemorrhagic shock, coming from blood loss, IV fluids do nothing to add oxygen carrying capabilities to the body. For that, we have to have blood, and we'll talk a little bit about blood administration towards the end of this presentation. Water is the most abundant substance in the human body. About 60% of the total body weight is water, which is located within two compartments or spaces. The largest of these fluid compartments is known as the intracellular fluid compartment, and it holds all the fluids that are found within the individual cells. 3/4 of all the body water is within the intracellular compartment. The remaining water can be found outside of the cell membrane in the extracellular fluid, extra meaning outside. There's two main components of the extracellular compartment: intravascular fluid, which is found within the blood vessels and outside of the cell membranes, and interstitial fluid, the fluid that is found outside the cell membrane, but not within any defined blood vessels. Quite often, your cells themselves will be bathed in this interstitial fluid. The relationship of the various fluid compartments goes something like this. With extracellular fluid, you have interstitial fluid, intravascular fluid, as well as the intracellular fluid, and this comes up to mean the total water as far as found within the body. Now, the internal environment of the body is extracellular fluid, which bathes each body cell. An important balance has to be kept regarding the internal environment. Anytime this balance gets to leaning more towards one side or the other, or if it deviates in any way from normal, and we see this quite often when our patients have some type of trauma or serious illness, the body responds and attempts to bring it back into balance. Now, this tendency to maintain balance at all costs is known as homeostasis. And in doing this, we have some electrolytes that come into play. Now, in addition to the body fluids, there's some important chemicals that these electrolytes are, and they're required for life. Having too much or too little can lead to some really bad outcomes for our patient. These chemicals are divided into two main classes known as electrolytes or non-electrolytes. Now, we're not going to get into exactly breaking down what the electrolytes are at the chemical level of whether they're positives or negatives. That really doesn't matter to us at the pre-hospital level. But understanding the electrolytes, what they do, and what happens and how it can manifest when we have too much of an electrolyte or too little of an electrolyte is important. Now, electrolytes are measured in the same way as we do other medications. These are measured in milliequivalents, and it's put out as M, big E, little q. Now, there are some major electrolytes that we're going to look at, and we're going to focus in on mainly for this EMC 225 class, and these are sodium, calcium, magnesium, and potassium, and they all have a particular role to play in the body. Sodium and calcium have their greatest concentration in the extracellular fluid, and potassium and magnesium are more concentrated within the intracellular space. Sodium and calcium on the outside, potassium and magnesium on the inside. Again, imbalances in any one of these electrolytes can result in major problems, especially when we're talking about imbalances of potassium. Sodium is the most abundant extracellular ion or electrolyte that is in the body and is really, really important for the regulation of water. In the body, water follows sodium. So wherever sodium goes, water will be sure to follow. This is why sometimes your hands or your feet will swell when you have a really, really salty meal the night before. Sodium's also pretty important in allowing nerves to be transmitted in the body, as well as it helps with movement of calcium into the cell. And we'll talk about calcium here in just a little bit. Regulation of sodium happens within the kidneys, primarily through the reabsorption of sodium in the tubules of the kidneys. Now, there is a chemical known as aldosterone. Aldosterone is the regulator that maintains sodium and moves it in and out of the body so that we don't get overwhelmed. When the kidneys fail, then the ability of moving sodium in and out now becomes hampered and the patient can suffer. Aldosterone is secreted by the adrenal cortex and it increases renal absorption of sodium. Now, again, remember I said that wherever sodium went, water was sure to follow. And as a result of this, anytime we get some type of a change in sodium and the water balance, those are going to be really closely related. An imbalance in one will typically lead to an imbalance in the other. If you have a high sodium level, probably going to retain a lot of fluid. If you have hyponatremia, which is a low sodium level, then you're probably going to be a little bit on the dehydrated side. And so these are important to keep in mind as far as when you are assessing your patient. And again, a lot of y'all are going to be working in hospitals. And so you're going to need to be very familiar with the role that labs play. So this is kind of why we're digging into this now. So that was sodium. Let's move on to calcium. Calcium is necessary for the structure of bone and teeth. You know that. Your mom told you that since you were a little bitty baby. But it also functions as an enzyme for blood clotting and is required for certain types of hormones to be able to be secreted by the body, as well as to maintain the structural integrity of the cell membrane. Keep in mind, when the cell membrane ruptures, the cell dies. Two bad things happen when we get enough cells that die. Number one, we have organ failure, and number two, the contents of the cell become poisonous to the body. The one last thing that calcium does that is extremely important is muscle contraction. This is why if your patient is too high and particularly too low in calcium, the contractile force of the heart may be insufficient. Now, we're all aware that one source of calcium is dairy products, but there's a ton of other foods out there that you can take that will help you to get adequate amounts of calcium. When the body stores calcium, it's mostly kept in bone tissue with the remainder floating around in plasma as well as in some of the particular body cells. Now, inside the cells, as we talked about just a minute ago, calcium is necessary for muscle fibers to contract. Again, this is true for all muscles, but it's particularly true for the heart. And again, now we're not talking about electricity here, as we'll see in just a little bit with potassium, but we're actually talking about the contractile force of the heart. The strength of the contraction is directly related to the concentration of calcium that is within the body. Blood levels of calcium are closely regulated by the parathyroid hormone, abbreviated as PTH, as well as levels of vitamin C and a hormone known as calcitonin, which is secreted from the thyroid gland. Anytime that you've got a person that has some type of a thyroid gland problem, now physicians are going to be concerned about the level of calcium that's going to be in their body. We talked about calcium, now let's look at potassium. Potassium is necessary in the transmission and conduction of nerve impulses, maintenance of normal cardiac rhythms, and skeletal smooth muscle contraction. And in particular, it is critically important in the conduction of these nerve impulses. One little known thing is that potassium is also required for the glucose to be able to be converted into glycogen and to be stored in the liver, as well as so when later on the blood sugar level drops and the patient doesn't have any glucose stores to pull off of. Well, actually, there are no such things as glucose stores, but the body will begin to convert the glycogen back into glucose. If the patient is low in potassium, that will happen very, very slowly. Now, in this capacity of the glycogen deposits as well as working on the skeletal muscles, potassium works really, really closely with sodium, momentarily trading places with sodium across the cellular membranes to maintain electrical neutrality. This is known as the sodium-potassium pump. This action allows nerve impulses to be conducted from one cell to the next, just kind of like a bunch of dominoes. It becomes extremely important in the conduction of cardiac rhythms as well as the movement of calcium into the cell for muscle contraction. One of the things for those of you that are either in or have completed EMC 303, keep in mind that the telltale tall peaked T wave tells us that we've got too much potassium that's going on. To show you how important it is and the role that it plays, especially if you've got a patient that's got too much potassium, in states that use lethal injection for capital punishment, one of the drugs that they give is a massive dose of potassium. And so this potassium is given, it goes directly to the heart, and it immediately stops all electrical impulses in the heart almost immediately. And the potassium bolus is actually what causes the prisoner's death. Last one we're going to look at is magnesium. About 40 to 60% of the magnesium is stored in muscle as well as in bone. Most of what's left is stored within the cell and seems to be related and regulated by both potassium and calcium. Magnesium activates an enzyme that is known as ATPase. Now, it's not ATP as far as the same type of chemical that we're looking at for energy, but it is very similar to that. This enzyme is essential for normal cell membrane functions, or else it'll begin to break down, as well as the energy source for what makes the sodium-potassium pump work, because that is active transport and it requires energy in order for that to happen. Some of the physiological effects that you'll see in this will be that it relaxes smooth muscle. Now, one of the things, and we'll talk about magnesium as we get deeper in talking about respiratory emergencies, is the bronchioles are made up of smooth muscle, and they can constrict in severe asthma attacks. So if we give our patient albuterol, which is a bronchodilator, and it doesn't work, we may give them a dose of epinephrine, and if that doesn't work, then we move on to magnesium sulfate to relax that smooth muscle and to open up those bronchioles. Mag sulfate is also utilized in the stabilization of cardiac cells, and it reduces the potential for arrhythmias, and in particular, ventricular arrhythmias, which can be deadly for your patient. To maintain physiological homeostasis, there's got to be an exchange of electrolytes and water materials across the cell of the membrane. Now, the cell is not simple at all. It's very, very complex. The cell wall has a quality that's known as being semi-permeable, which means it lets some stuff pass through while others it filters out. Many different types of substances have to come across this cell membrane, including carbon dioxide going out of the cell as a waste product, oxygen coming in, nutrients, fluids, and the nutrients primarily one being glucose, as well as different electrolytes. Now, there's three different ways to move substances across the cell membrane. We'll talk more about these when you get into the advanced sequence. But for right now, memorize them for me. One is diffusion, the second one is facilitated diffusion, and the third one is active transport. So you might want to look the definitions up of each one of those. Diffusion and facilitated diffusions are passive processes that require no energy whatsoever. Active transport is the exact opposite. It requires energy to be expended by the cell. Diffusion occurs when concentrations of various substances become higher on one side of the semipermeable membrane as related to the other side. When this difference occurs, a gradient or an imbalance is created. The side of the cell with a higher concentration is said to be hypertonic, hyper meaning high, tonic referring to the number of particles with respect to the other side. Now, keep in mind that it's hypertonic because we're comparing it to what's on the other side of the cellular membrane. If we were to take that fluid and compare it to another fluid, it could potentially be hypotonic or even isotonic. So what you're doing is you're comparing one thing across the membrane to the other side of the cell. The other side of the membrane with the lower concentration is said to be hypotonic in relation to the other. These two concepts are really, really important for you to understand, especially when we begin starting IVs and giving fluids and we see fluid shifts. So if you don't understand them, please contact me and let me know, and we'll do some additional work on this. When both sides of the cell membrane have an equal concentration of the substance, homeostasis exists, it's in balance, and the system is said to be isotonic. These concepts underpin the rationale for IV therapy, and that's why I said these concepts are so very important. IV fluids with a solute concentration, which is their concentration, that is less than that of blood, is to be hypotonic solutions as compared to blood. An example of a hypotonic solution would be 0.45% sodium chloride, or 1/2 normal saline. We'll talk more about normal saline in just a little bit. Substances that have a concentration that is equal to that of blood are said to be isotonic. Lactated ringer is another IV solution, and 0.9% sodium chloride, or normal saline, are examples of isotonic fluids. An example of a hypertonic solution would be D50W, or 50% dextrose. Although it's not an IV fluid, it is a medication. We don't use it nearly as much anymore because we'll talk more about why that is. In the past, it's played a major role in pre-hospital care. One of the most important substances that passes across the cell membrane is water. Without water moving in and out of the cell would die. Water diffuses readily across the cell membrane from an area of higher water concentration to that of lesser water concentration. The diffusion of water in this manner is called osmosis. It's moving across a semi-permeable membrane. One of the most important aspects of the extracellular fluid and the internal environment is blood. Blood's the main element involved in the oxygenation process of the body cells, as well as the transport of nutrients such as glucose and the movement of hormones to maintain homeostasis within the body. It also plays an important role in getting waste products out of the cells and moving them to the liver, the lungs, or the kidneys, or even to the intestines for excretion, as well as temperature regulation. Remember that the red blood cells are tiny heat-carrying vehicles, and that's why they are so critical. Now, blood, like everything else in the body, is a complex substance that's divided into two basic components, plasma and formed elements. Plasma is the actual liquid portion of the blood. Plasma moves in and out of the capillaries with a fluid that is circulating between the cells And remember, that fluid that is going in and out between the cells is known as interstitial fluid. Of the blood, plasma is about 92% water, and it does carry around a certain number of the formed elements. Now, the formed elements within the blood are different types of plasma proteins, plasma lipids, electrolytes, nutrients, and other important, well-known cellular elements such as red blood cells, white blood cells, and platelets. Now, the formed elements make up about 40 to 50% of the total volume of the blood. The continuous movement of blood keeps the formed cells dispersed throughout the plasma where they're able to move freely and carry out some of the following. Number one, respiratory. They deliver oxygen to the cells and carry carbon dioxide away. There's a nutritional function. It delivers things such as glucose and other carbohydrates to the cells, amino acids, fatty acids, vitamins, minerals, and other elements that are important to health and growth. There's also a regulatory function. It moves around electrolytes and hormones so for example, if we didn't have the movement of the potassium, then we would not have adequate conduction of the nerves or the nerve impulses within the heart. It's also excretory. It removes different parts of dead or dying cells that is a normal part of living, as well as some of the waste products, primarily that of being carbon dioxide, and when carbon dioxide and other acid-like substances mixed with water become acids. It also has a protective mechanism against injury when we get hurt, as well as any type of virus or bacteria that comes in. Now, there's three major classes of blood cells. The first are red blood cells, and they are also called erythrocytes. Erythrocytes, or red blood cells, contain an iron protein that you've heard me talk about known as hemoglobin. Hemoglobin transports oxygen and carbon dioxide. For every molecule of hemoglobin that the body has, it will carry 4 molecules of oxygen. About 45% of the blood is made up of red blood cells. Now, the percentage of red blood cells that is present within a sample is known as the hematocrit. The hematocrit is an important measurement because it allows us to know how well oxygen and other nutrients are being transmitted. White blood cells, or leukocytes, sites referring to cells, are the second type of cells found in the body and the blood. These leukocytes, some of them that are called neutrophils, and they're specialized different types. They combat infection by literally eating up bacteria. There's other specific types of leukocytes, some that are known as like lymphocytes, that produce antibodies to help fight infection. Those have gotten an overwhelming workout over the last 3 years since we've been fighting COVID. The last type of blood component present is platelets, or thrombocytes, which is responsible for blood clotting. Now, blood clotting is a very important thing, and we need it, but we don't need it when we've got a patient that is having a heart attack as a result of a clot that's formed in the heart. So, what role do IV fluids play in all this? Well, there's 2 major classes of IV fluids, colloids and crystalloids. Colloids contain compounds that are of really, really heavy weight, usually proteins, and they don't move across that cellular membrane very easy. In addition, they exert what is known as osmotic pressure, which means they are kind of like sodium in the fact that they tend to pull water into the intravascular space. Now, think about this for a minute. So if we've got a patient and we give them a colloid and it's beginning to pull water into the blood vessels, then that's going to help increase the volume, which is also going to help to increase the pressure. Now, we don't use a lot of colloids in pre-hospital, but I suspect that that'll change over the next few years. If we give a patient a small amount of a colloid, we can get a greater than expected increase in intravascular volume. Again, this is because water will pull, or the colloid itself will pull water from the interstitial space and from the intracellular compartment into the blood vessels. Now, there are certain types of colloids you need to be familiar with. One's known as plasminate. Plasminate, Plasmanate, and you know if I spell it that it's important. Plasminate is a protein-containing colloid. Remember, it does not move across the cell very well. The principal protein within plasminate is one that's known as albumin, which is basically in a suspension along with other proteins in a saline solution. This is utilized quite often to help to bring up the pressure in a critical patient. Now, crystalloids are something that you and I are going to be very, very familiar with and very much exposed. Crystalloids only carry two things: water and electrolyte. Now, there may be a mixture of electrolytes in there, but it's electrolytes nonetheless. These substances move across the cellular membrane really, really easy and very, very well. Crystalloids are the primary solutions that we use in EMS. Because there's a bunch of different preparations, it's often helpful to put them into a classification system as to how it's related to plasma. Isotonic, remember we talked about isotonic meaning that it's balanced. Isotonic solutions have an electrolyte composition that's very, very close to that of blood plasma. When it's placed into a patient that has good hydration, there's no massive fluid shift or electrolyte shift that follows as a result of those. That's not true for hypertonic solutions. Hypertonic solutions have a higher concentration than does plasma. And as a result, these fluids have a tendency to cause a fluid shift that pulls it out of the intracellular compartment into the extracellular compartment when administered to a patient that has normal hydration. As a result of this, we can begin to see some cell dysfunction because, in other words, the cells are becoming dehydrated. Lastly, there is a movement or a diffusion of the particles, also known as solutes, in the opposite direction. Last one we need to look at are hypotonic solutions. Now, they have less of a concentration than does plasma. When we give them to a normally hydrated patient, they cause the movement of fluid from the extracellular compartment into the intracellular compartment. Later on, solids will begin to move in the opposite direction. And that'll be important as we talk about fluid shifts a little bit later on. So what are the solutions that we utilize in EMS? So let's take a look at lactated ringers. We describe lactated ringers as one of the most frequently used IV solutions for patients that are suffering from hypovolemic shock. It is an isotonic crystalloid solution, make sure you know that, and it contains the following electrolytes: sodium, potassium, calcium, chloride. Now, remember those electrolytes that are in lactated ringers, because most paramedics, if you ask them what is in lactated ringers, they would just simply go, I don't know. You're going to be different. In addition to the electrolytes that are mentioned just now, lactated ringers has 28 milliequivalents of lactic acid, which acts as a buffer in the body. So what's the mechanism of action? How does it work? Well, lactated ringers, or LR, replaces water and electrolytes. It's the solution that most closely resembles normal body fluids in terms of electrolyte concentrations. When do we use it? For any type of patient that has really severe hypovolemic shock, burns, especially severe full thickness burns, or to KVO, keep a vein open IV. Contraindications would be that we don't want to use this in patients with congestive heart failure or renal failure simply because we can put them into pulmonary edema rather quickly if we overwhelm them. Some of the things that you want to be wary of, just like I said just now, is that when we give patient lactated ringers, especially if we're giving them a bolus, we need to listen to their breath sounds to make sure that we don't overload them. There's not many side effects when we're using it for normal dosages and for normal interactions for emergencies. Crystalloids such as lactated ringers diffuse out of the intravascular space and into the surrounding tissues in less than an hour. Therefore, it's important for you to remember that if you want to replace 1 liter of lost blood, you're probably going to have to give 3 liters of LR. You have that 1 to 3 shift of when you're giving the blood in, it's going to be coming out of the cell, out of the vasculature within about an hour. When you've got a really severely hypovolemic patient, LR should be infused through a 14 or 16 IV gauge or gauge IV cannula or needle. We should give these administered wide open until we get a systolic blood pressure of somewhere between 90 to 100. We especially in trauma. Now keep in mind that we're engaging and we're shooting for that 90 to 100 blood pressure, systolic blood pressure, because that's enough to perfuse the brain, the heart, and the kidneys. But it's not so much that it's going to, number one, dislodge clots and cause our patient to begin to bleed elsewhere, or to have so much fluid in there that it begins to dilute the clotting factors. LR is supplied just like most all of our other IVs in 250, 500, and 1,000 milliliter bags. Let's talk about D5W, or 5% dextrose. It's classified as a hypotonic dextrose-containing solution. Now, we don't use D5W a whole lot anymore. We typically would use it more so with diabetics. When we're not wanting to give a bunch of fluid back to our patient, though, we can utilize D5W. It also can be used to administer IV medications. Now, like I said, it is hypotonic, which does a really good job of preventing circulatory overload in patients with heart failure. So how does it work? Well, it provides nutrients in the form of dextrose as well as water to raise the blood pressure up. When do we use it? Well, primarily to give emergency medications. We can also use it to dilute medicines for when we're going to be giving them IV. Now, D5 is contraindicated anytime that we've got a patient in a hypovolemic state. Any type of dextrose-containing solution should be avoided in patients with head injury or stroke because it can lead to increased intracranial pressure. Dextrose-containing solutions are acidic and may produce local venous irritation. This is particularly true if you're giving high percentages of dextrose, such as D25 or D50. If we allow it to infiltrate, to go into the tissue, basically what happens is the tissue becomes necrotic and rots away. It's important with any IV fluid that we watch for any type of circulatory overload when we're given D5W, or in particular, any type of infiltration that comes about as a result of like swelling. Not a lot of side effects as far as when we're using it in the correct dosages. Now, D5 is usually given through a micro drip, which is 60 drops per milliliter. We'll talk more about how to calculate a drip rate, but basically what we want to do is we just want it to drip fast enough just to keep your vein open and keep it from clotting off. Again, just like we saw with the LR, with the 250, the 500, and the 1,000 milliliters, it's also provided in those size bags, but it can also go down to as low as 50, 100, 150 as well. 0.9% sodium chloride, we also just simply refer to that as normal saline, and it's classified as an isotonic crystalloid solution. The use of normal saline has a bunch of different applications in emergency medicine. Normal saline contains quite a few ions of sodium as well as chloride. Now, because this concentration of sodium is so near that of blood, the solution is considered isotonic, hence that's why we call it normal saline. NS is really, really helpful in heat stroke, heat exhaustion, and diabetic ketoacidosis. How does it work? Well, normal saline replaces water and electrolyte. And when do we use it? Again, like we said, anytime we have a heat-related emergency or in hypovolemia. It is pretty effective as far as helping to reverse some of the diabetic ketoacidosis issues in particular, because what we're now beginning to do is we're diluting some of the high levels of glucose that are there. Now, be really careful when you're using normal saline with patients who have heart failure, because circulatory overload can be really, really brought about as a result of its use. Normal saline, unlike LR, which has several different electrolytes, only has sodium and chloride. When we have a large amount of sodium that's given, it's quite possible for other important physiological electrolytes to become depleted and washed away. If you're going to have to give a large amount of normal saline, it might be your best idea to use LR. There's rare side effects when we use it in the right way. We have really no negative interactions in the emergency setting. Now, how much and how fast are we going to give it? Well, it depends on the situation. In heat stroke, diabetic ketoacidosis, and freshwater drowning, it's quite often that you'll probably be called on to give the fluid really, really fast. In other cases, you may only want to run that at about 100 milliliters per hour, and we will administer it IV. Normal saline is supplied in 250, 500, and 1,000 milliliter bags. Now, it's important because it'll look the same. It'll come in very similar bags. Do not mistake in normal saline for irrigation for that's used for IV use. It could be really, really catastrophic for your patient. So what kind of IV fluid should you use? Well, usually the decision of what type of IV fluid to use is already set up by your protocols. Now, it's important for you to be familiar with the types of fluids that we've talked about in this chapter, as well as the types of fluids that you will utilize either in your department or within your agency if you're working in a hospital. There's two general types of IV administration sets that you need to be familiar with, and you'll learn about these if you have not already done so in the lab. First is a macro drip, or a standard set, and it delivers in the neighborhood of anywhere between 10 to 20 drops that will make up 1 milliliter depending upon the maker of the IV set. The micro drip set delivers anywhere from usually about 60 drops per milliliter. And if we're going to give a large amount of fluid, then use a macro drip, the larger one, to be used, because it's going to take you forever to get fluid in if you're using a micro drip. When you're going to beginning to get a medication, try to use the micro drip set. Now, this is especially true if you're using medications as piggyback infusions. One of the nice things that I'm beginning to see now is that many EMS agencies are beginning to use electronic pumps for giving a lot of different medications, whereas we just fed them before by gravity. Not a good thing to do. So when we start our IV, where do we start it? Well, typically you want to use the large veins of the forearm. These are usually the most accessible and the least painful for the patient. When these aren't available, as you quite often will see in shock and trauma, then you go with whatever you can get. Often you can start, in the past we've used the legs of the vein as well as the external jugular in the neck because they're considered peripheral. We don't use those a lot anymore because we can go with an IO. Basically, when you've got a medical emergency or a traumatic emergency, the rule of thumb is get an IV started wherever you can with the largest gauge needle that you possibly can. Most of the time, the antecubital site or the interior aspect of the elbow is what's going to be preferred. So let's talk a little bit about blood and blood transfusions. When mismatched blood is transfused, the donor's antibodies can bind to antigens on the recipient's red blood cells. Now, this is known as a transfusion reaction, and it causes the red blood cells to begin to clump together. The correct term for that is agglutination, agglutination, agglutination. And then what happens is the red blood cells begin to hemolyze or break apart or fall apart. Again, as we said before, when any cell, but in particular a red blood cell, begins to break apart or rupture, it no longer carries oxygen. Transfusion reactions can be prevented only by being really, really careful and performing cross and type matching between the donor and the recipient. Now, on a regular basis, you're going to transport a patient that's getting blood. Watch these patients really, really closely for signs and symptoms of a transfusion reaction. How severe the reaction is going to be is going to depend upon how severe the incompatibility is, how much blood is being given, and how fast it's being administered. Like most anaphylactic reactions, and that's in essence what this is, onset's usually rapid, either during or immediately after a transfusion. Sometimes it can happen several hours later, but this is rare. Signs and symptoms include anxiety, facial flushing, pain in the chest, the neck, or the lower part of the back. Heart rate will go up, they'll become cold and clammy, blood pressure will drop, sometimes they'll have some nausea and vomiting. Dizziness will ensue, your patient will often develop hives, and possibly even a fever. When signs and symptoms of transfusion reaction appear, stop the transfusion right away. Let the doctor know as soon as you possibly can and get a crystalloid solution, LR, or normal saline, going for medication and administration maintaining. And most of the time, you'll have one of those going anyway. Most of the time, a fluid bolus is going to be given to assure good urinary output. Because remember, as your patient goes into shock, circulation to the kidneys is one of the first of the big three organs that shuts down. An antihistamine such as Benadryl may be indicated for your patients. Now, one of the most serious effects of a transfusion reaction is renal failure because of this clumping and the clogging of the tubules within the kidneys. And this can start within a few minutes to a few hours and can progress to the death of the patient. Like everything else, the things that you do for your patient come with a risk and a benefit. Before you give any medication, IV fluids are medications just like any other medication that you're going to give. Make sure you know what you're giving and whether your patient is allergic to it.